Today, we will talk about a new study that just came out about the safety of CGRP inhibitors. So the title of my short talk is "Are Triptans Safer Than We Thought and CGRP Antagonists Less So?" So when the CGRP inhibitors came out on the market, we were all surprised that they are so safe, and we're worrying about there will be another shoe to drop. But a little bit about CGRP in general. It is a widely distributed neurotransmitter, both in central and peripheral nervous system, and provides innervation to all major organs, has an effect on every organ system in the body, respiratory, endocrine, GI, and so on. And it has several functions, vasodilatation, inflammation, nociception, hyperalgesia. Actually, CGRP is probably the most powerful vasodilator in the body. And that's why we were concerned, even when the drugs were being developed, that if you inhibit this powerful vasodilation mechanism, there will be vasoconstriction, and these drugs could be dangerous. In fact, the data has shown that these drugs are really safe and do not cause vasoconstriction. And CGRP inhibitors, and we have now 4 injectables, three intramuscular subcutaneous, rather, 1 intravenous. We have 3 oral GPANs, that is rimegepant, Nurtec, ubrogepant, Ubrelvy, and atogepant, Qulipta, and we have one abortive nasal spray, Zavegepant, or Zavspret is the brand name. So we have all these drugs, and they seem to be very safe as far as side effects, and supposedly safer than triptans, which have been shown to have some vasoconstriction. So when the drugs came out, they were amazingly safe. But then little by little, we started to see patients who had worsening of their Raynaud's syndrome, severe worsening. I've had several patients. One patient had dramatic relief of her migraines, but her hands were always painfully white and vasoconstricted, so she had to stop the medication. So these were occasional reports of vasoconstriction in some patients. Overall, they seem to be, again, very safe compared to other drugs, maybe even compared to triptans. But now the drugs have been on the market for over 5 years, and this study just came out, which prompted me to record this talk. Looking at over 58,000 people who started a CGRP inhibitor. They looked at 900,000 people, found these patients who started a CGRP inhibitor, and they found that there was a high rate of the primary endpoint, meaning vasoconstrictions. And initiation of CGRP inhibitor was associated with a significantly higher rate of one secondary endpoint, that is ischemic stroke. And the hazard ratio was 1.26, but there was no signal as far as 4 other endpoints, myocardial infarction, revascularization, and so on. So it's still pretty safe-looking group of drugs, because it was just a slight increase, but this could lead to more studies looking at how safe these drugs really are. And again, we've had plenty of anecdotal observations, and my colleagues as well, and there are case reports of vasoconstriction caused by CGRP and other side effects that are rare, but clearly caused by CGRP inhibitors, such as hair loss and actually mood changes, rare, but they're definitely related to these drugs. So again, to summarize, CGRP inhibitors are still fairly safe drugs, including for patients with vascular disease, most likely. But are they safer than the triptans? So most of my talk now will focus on the safety of triptans. So here's a 2004 report, Triptans and Migraine, the risks of stroke, cardiovascular disease, and death in practice. So 63,000 migraine patients in general practice found no association between triptan prescription and stroke. Myocardial infarction, all-cause mortality. So the authors concluded, in general practice, triptan treatment in migraine does not increase the risk of strokes, MI, cardiovascular death, ischemic heart disease, or mortality. Next is a consensus statement from the American Headache Society that came out in 2004. The incidence of serious cardiovascular events with triptans in both clinical trials and clinical practice appears to be extremely low. And long-term daily intake, acute prophylaxis of triptan is probably safer than taking topiramate, valproic sodium, Depakote, amitriptyline, and other prophylactic migraine drugs. That's my interpretation, that these drugs like topiramate and Depakote carry, I think, more side effects. Now, triptans are not approved for daily use, and there is an argument about do triptans cause medication overuse headaches? That is, do they make headaches more frequent or more severe? I will talk about this at the end. And here's another triptan safety trial published in 2004 as well. That's the same study I just showed you, actually. And here's another study looking at 429,000 patients who filled their first triptan prescription. This is a study published in JAMA Neurology in 2024. It's a recent study. So while triptan initiation was associated with a statistically high relative risk of ischemic events, the absolute risk for individual patients was exceedingly low, less than 1 in 30,000 new users. For the individual patient with low background cardiovascular risk, the risk of an ischemic event after triptan initiation was very low, and nearly all patients who experienced cardiovascular events had pre-existing risk factors, and the majority were older than 60. So if you exclude patients who have obvious cardiovascular problems and who are older, the risk is very low. Now, the age is not a contraindication for prescribing triptans. I have a patient who is 90 years old. I have many patients in their 80s. Fortunately, with age, migraines tend to go away, especially after menopause in women, but also in men with age. But there are still people who are in their 80s and 90s who still have migraines. And again, I do not withhold triptans from those patients unless they have multiple risk factors for ischemic heart disease. So age itself is not a contraindication. This was a presentation at the American Headache Society in 2022 that I don't think has been published yet. So it's Mass General Patient Data Registry, risk of major adverse cardiovascular events in patients pre-existing cardiovascular condition. So these are the patients who you're supposed to avoid prescribing triptans. And they found that MACE, major adverse cardiovascular event, occurred in 1% of patients on triptans, 3.8% of those taking NSAIDs, and 4.5% taking opiate barbiturates. So a little bit about NSAID safety, triptans versus NSAIDs. So diclofenac, ibuprofen, and naproxen were associated with increased risk of hospitalization for heart failure. So NSAIDs, again, just like the previous slide showed, are not safer than triptans. And here's another study looking at patients with rheumatoid arthritis, showing that NSAIDs elevate risk of myocardial infarction, stroke, heart failure, and venous thromboembolism, with the risk varying by specific NSAID and dosages. So practical issues also about triptans. People are afraid to prescribe more than what's on the label. Well, we have rizatriptan that's officially FDA approved to be taken up to 3 times a day, because that's the way the registration trials were conducted. All the other triptans used a study design that allowed patients to take it only twice a day, and that's the way the FDA approved it. But the top 5 triptans have very, very short half-life, 2.5 to 3 hours at the most for sumatriptan, elatriptan, rizatriptan, almotriptan. Zolmitriptan is the 5th. And many countries sell these triptans without a prescription for many years. In Germany, it's like over 10 years, and UK was the first one actually to approve an OTC triptan 18 years ago. And so far, there has not been any signal that they cause any cardiovascular problems greater than NSAIDs. So maximum daily, weekly, monthly dose. So 9 pills a month is what most triptans come in the package. Because again, that's the way the trials were conducted, that on average patients were taking 9 pills a month, and that's the way they approved it. But there's no reason to suspect that taking it 15, 20 times a month is more dangerous. And mixing triptans is something else that is a major misconception. If you take one triptan, you're not supposed to take another one for 24 hours. You can take a same triptan 2 hours later, according to the label. So I don't see the reason why you cannot take one and 2 hours later take a different one, especially because, again, the half-life is short and they don't increase the risk of any side effects if you mix them. The cost had been a problem, buying more than 9, what insurance gives you. But now sumatriptan, rizatriptan, elatriptan, last time I checked, you can buy for like 60 cents, especially on mail order pharmacy or Mark Cuban's Cost Plus pharmacy or Amazon pharmacy. So cost is no longer an issue as well. And medication overuse headache is clearly a myth. And this is a statement from an article published by Elizabeth Loader from Harvard in 2017. They reviewed all the data and they concluded that these findings raise serious questions about the value of withholding or withdrawing symptom-relieving medications from people with frequent headaches solely to prevent or treat medication overuse headache. The benefits of doing so are smaller and the harms larger than currently recognized. The concept of MOH should be viewed with more skepticism. Until the evidence is better, we should avoid dogmatism about the use of symptomatic medication. Frequent use of symptom-relieving headache medications should be viewed more neutrally as an indicator of poorly controlled headaches and not invariably as a cause. So I'm submitting actually a citizen petition to the FDA to try to get triptans converted to over-the-counter drugs. If you feel like you want to contribute, please send me a letter supporting the idea that triptans should be available without a prescription over the counter like they are in many, many countries all across the world. Thanks for your attention. Take care.